So my name is Marion Subklewe. I'm a professor for hematology with focus on cellular immunotherapy at the LMU in Munich, Germany. And I'd like to give you a few data updates on the topic antibodies in AML. And I just yesterday presented an overview of novel antibody strategies in AML at the SOHO meeting. So to give you a short version of the 15-minute talk, I just want to remind you that there are different immunotherapy or antibody-based platforms that are currently in clinical testing in AML. So we have the conventional Fc-engineered antibodies that target surface antigens. We have ADCs. We have the T-cell recruiting antibody constructs that are targeting surface antigens, but also intracellular target antigens that are presented in the context of MHC molecules. And clearly we have the checkpoint molecules who are on the one hand targeting checkpoint molecules, but also unleash endogenous T-cell responses. And there's one common challenge in AML for all these antibody-based strategies, that is the choice of target antigen. And clearly we cannot answer currently what is the most suitable target antigen. And most of the target antigens that are currently being employed in all these clinical trials are lineage antigens. So they are not solely expressed on AML, but for example, the CD33, a common target antigen in AML, it's expressed on monocytes and macrophages and is clearly not leukemia specific. So in all these trials, we're looking for the therapeutic window. I'll just want to focus now on the T-cell recruiting antibody constructs, which are all still in phase 1 trials. And in particularly, I'd like to focus on AMG 330 and AMG 673, sort of the siblings of blinatumomab in ALL. So the most advanced trials of these two is AMG 330 that has recruited 60 patients, that's given similar to blinatumomab. And the most common side effect has been cytokine release syndrome, and this is mitigated through TOSI, but also implementing dose steps. And we are currently still going up in the dose. And I think one of the challenges is probably target antigen sync. So we have to increase quite a number and include quite a number of cohorts. We've seen responses in 8 patients now in the higher cohorts. And I think very interestingly, this trial will be augmented to include MRD positive AML patients. And I think this is the most suitable clinical situation for applying BiTE molecules, as we've already seen in the blinatumomab setting. And the other molecule is AMG 673, the half-life extended, very similar molecule to AMG 330. We have included 30 patients so far. So now here we don't give this as a continuous infusion, but as short-term infusion. But again, we also have implemented dose steps to mitigate CRS. And we've seen responses in 11 patients. We are very excited. It might be easier to build up a significant serum level, but clearly this is also still ongoing. So I would sum up that the T-cell recruiting antibody constructs are still sort of struggling in advancing in the clinical trials. It's taking slower than we expected for several reasons, but I think as soon as we move up further in the line of treatment, I think there's a great promise in these constructs. And with this, I'd like to finish this short summary and I'd like to thank you for listening. Thank you.